So now it's your opportunity. This is a great opportunity to ask them questions about myeloma, generally speaking. It's tough for them to answer specific questions about your particular case, so I would try to avoid those types of questions. But if you want to ask strategy questions or anything like that, please let me know. So I will bring this microphone around and I'll just try to find you in order, and then they can answer your questions. Okay, so.
Thank you, and thanks for giving up your Saturday. This is just wonderful. A question, these mutations that cause a patient to get into the high-risk category, are you all confident that you've identified them all? Because I've heard of patients who have what they call functional high risk, can't see any mutations, and yet don't do well. So it looks like you're shaking your head.
We're not confident.
Yeah, right. Yeah, we're confident that we don't know them all. That's what we're confident about.
Yeah.
I think fish testing what we currently do is we're looking at the things that we know about, and there's a lot of things we don't know about. You're describing exactly the scenario that we would fall into, which is for all the world, the patient appeared to have standard risk myeloma, and then 18 months after diagnosis is relapsing already. And that's where I do believe that we're going to start moving more sophisticated ways of looking at myeloma earlier in the course.
We're learning a lot.
Yeah.
In fact, many years ago, when the deletion 17 became like one of the bad guy, Dr. Barloghi was one of the first to describe that some of the deletion 17, they were doing okay. And now we know that if the mutation is present on both chromosomes, is worse than one single chromosome, the biallelic, and then the addition of the one abnormality. We don't know all of that. It's an evolution, it's evolving, we are learning, but it's definitely clear. That's the reason why the ISS staging system went already through revision, so because we're adding things. But you are correct. And actually, when I started to treat patients with myeloma and we didn't have genetics, I used to sit on the room and they were asking how long I'm going to be in remission, what's going to happen. And I would say, time will tell us. If you are in remission 1 year after transplant, maybe we can take a deep breath. But 2 years is better, 3 years, because time was an indicator of the high-risk disease. So if the patient were progressing very quickly within the first year, we knew that we were dealing with a difficult disease.
Hi. How is the MRD status established? Is that a normal test that's done? I understand it's from the bone marrow testing. Is that standard after a transplant to do that?
Yeah.
So MRD, or minimal residual disease, and sometimes it's called measurable residual disease, the test done in the bone marrow, where we take where they first do the regular testing to look if we see abnormal plasma cells, but there are two tests. That's with immunohistochemistry. But then there are two tests that are done, which I talked about, the next generation sequencing or next generation flow. So flow takes the aspirate of the bone marrow, and there are these markers that tag the cells, and we find which are the abnormal or cancer cells and look very deep into it in terms of how many cells we can find. So depending on how many markers we are looking at, the depth of how we can find these cells are. So most flow tests are now sensitive to 1 in 100,000 cells, but you need a bone marrow biopsy to be looking at that MRD assessment. And flow is really dependent on which institution you get it done at. Some centers have a very established flow team that can do these tests, and some do not, so they do not even run the flow panel. The other test, which is more standard and FDA approved, is the clonoSEQ test, which is looking at the VDJ sequence in the tumor. The issue or the main thing about this is you need to have the baseline before you are looking to see whether it's eradicated. You need a baseline clone to know what every clone is different for. It's like a barcode for every myeloma, and you need to have that barcode known right in the beginning. So you need the baseline sample of the bone marrow biopsy where the myeloma was there to find that barcode and then look for it in the bone marrow when there is no evidence of myeloma. And because they can look very deep, they can say like, okay, 1 in 1 million cells, even if there's one barcode found in 1 million cells, they'll say that that's positive. So it's looking at a lot of cells and looking very deep. So that's the test that you want to ask for after, maybe if you're thinking about looking at what your MRD status is, that would be the thing to look at. It's called next generation sequencing by clonoSEQ, or adaptive is the most commonly one that's FDA approved. And then now there are more, like, of course, patients don't like to do bone marrow biopsies and things. So there are newer novel technologies that are being studied. It's not yet standard, but looking at how we can detect it in the blood, or like circulating tumor cells, or looking at other mass spectrometry or other things which could be good indicators or markers of what's going on in the bone marrow. So hopefully more to come with that, where things will be, approved, which is not.
Okay, great. What other questions? Who else? Okay. Peter?
With the question of doing the MRD, is that a clinical level test that's being done now on a regular basis, or is this one more to the research side where it's being done? Just wondered if my oncologist would be interested in finding it out, that we just go do it, or do we need to have certain triggers to make you want to go to do another bone marrow biopsy so that you can do that?
Yeah.
What does it take to trigger that?
I can go.
That's a good question.
Shouldn't
Shouldn't you answer that?
So again, MRD is a very controversial area currently. I'd say that in terms of, so to your question of who it makes sense to check it in, so we know that it's only a test that's likely worth doing in people whose myeloma looks like it's in a deep remission by the standard test. So the blood work, we want to see that the M spike is gone, basically. Light chains, we want to see that they're normalized, and that we know that people whose myeloma that isn't not that good, not that deep of a remission, there's no point in doing an MRD test because we're going to find the cells there. In terms of who it makes sense to do this in, period, it's typically only people whose myeloma is in a deep remission, which is probably a complete response. Maybe very good partial response, probably a complete response. But then beyond that, in terms of who actually should be getting it among those people who would sort of quote unquote qualify for the test, that's really where things are controversial, because again, as mentioned, and as you've heard this morning, there's some data suggesting that maybe we should be using MRD testing to make treatment decisions, but those data are not definitive yet. And so the question becomes, okay, we're doing a bone marrow biopsy, we're running this test that costs $1,000+, and then we're getting this result back, and we don't necessarily know what to do with the information. As I mentioned earlier, for people who are MRD negative, meaning we can't see any myeloma in there even using this super sensitive test, we don't yet have data saying, okay, we can stop therapy because we're good. And then conversely, like as you heard for this case that Dr. Shah presented, the person who maybe went for a transplant and the MRD test was positive, we again don't have data saying, okay, that's a person we should take for transplant because their MRD test is still positive. So just to highlight the fact that we can get this test, it's prognostic clearly in the sense that people whose bone marrow biopsy is MRD negative, myeloma almost always stays under control for longer, and in some studies they've also been shown to live longer than people whose bone marrow biopsy is positive. But that doesn't always tell us that we should do something different now to get to that MRD negative state. So that's a really long way of saying I'd probably only do MRD testing in somebody who's in a complete response by other blood markers. And then beyond that, it's really unclear now in 2023 what to do with that information, even once we get it.
But that's the reason why we always discuss with each other and kind of, have all these controversial questions, and we don't necessarily agree with each other. So if you go for a second opinion, you go to somebody and tell, I'm going to do this, and then you go to one of our colleagues. It's a little bit different approach. I chase the MRD, and I learn over the years to use it, and I de-escalate and escalate the maintenance, and I have a lot of good success stories with that, and I've been doing that for many, many years, so I believe it. And so particularly if you are high risk, I do it, and I do it again a little bit earlier, and I don't let you go until I know for sure that you have reached that level. And then I follow yearly sometimes to make sure that you remain MRD negative, and I attack the clone before the clone is back in your blood. So, but it's different. What Sasha was saying is absolutely correct. We don't have any data. It's based on our experience of how we incorporate the data into the practice and how we, how aggressive we are. If I have a 40 years old patient, I do have a lot of these. And yes, Thursday I saw my youngest is 19. You better believe that I chased the MRD to the bones because he's 19 years old, and I want him to stay in remission the longest time possible.
I would say really just to Jenny's point from earlier, this is really an example of where clinical trials are critical because we really need, the only way we're ever going to know the answer to this is if clinical studies are done. And the only way those clinical studies are done successfully is if people, like all the people sitting in this room, all of you participate in those studies. So you can help us to not be sitting here in 2025, 2026, still saying, we really don't know the answer, although this is our gut feeling. It would sure be nice to have some trial data that really gives us an answer to this. So consider helping us out by participating in those studies, which are ongoing now to help to answer this critical question.
So my question actually was about MRD2, and you've partly answered it, but I just wanted to say that I think I was one of the first patients at Duke to get an MRD test back in 2013 after my first transplant.
My gosh, we've been doing it for a long time.
Yeah, and I've gotten a lot of them over the years, and I was a little bit, so I know that bone marrow is, it's not a smoothie. Plasma cells don't get evenly distributed around, and so I guess I wondered how consistent are MRD results. Mine have not been particularly consistent over time.
Myeloma, no. That's the problem.
Yeah, I've had times when my myeloma was clearly progressing from other labs, but the MRD test came out negative, and I wondered if that's just me or if that's everybody.
It's patchy, right? The multiple myeloma. So I think you do have a clinical trial where you do multiple bone marrow. Do you? Who does it? But there are actually people that do multiple bone marrow biopsy on the same day to locate, to see with the PET-CT guiding. I thought you guys had a probably. But yeah, it's not perfect. That's the reason why, hopefully we will develop a better test, like Irvi was mentioning about the mass spec. Can we combine the two of them? Yeah. But no, not perfect, Selena.
Okay, because I have an incredibly inquiring mind. But first I want to say I have MGUS. My husband, it was unfortunate, but passed away after 300 days ago from multiple myeloma high risk stage 3. And how do I have MGUS is one of those questions, but I'm not going to ask that question. I wanted to say I'm reassured that y'all are all young and you won't be retiring anytime soon. So I am very hopeful for all kinds of reasons. I wanted to ask about the concept in this woman in the back, maybe I keep hearing sequential stem cell therapy. That's one of my questions. Is it like first time, then there's a fail and you do a second time? Or is it sequential? My other question is, when I harvest my stem cells, I should be MRD negative, if I should ever, or whoever does. MRD positive or MRD negative? The idea of harvesting. And then the last piece would be, do you have to have a stem cell transplant prior to CAR T?
Well, I'll tackle the first one. So first, thank you for calling me young. It's been a while. I don't think I remembered all the questions you asked, but it's okay. But I will. Yeah, see ya.
We like that a lot,
but
too.
In terms of the sort of the real basics about transplant, there's something called tandem transplant where you do one transplant, you recover 2-3 months later, you do another transplant. That's called a tandem transplant. That was common for a while. It's more common in Europe than the United States. Some people still do it. The more common approach is somebody has a transplant and then it works for a good long time, more than 3 years. And then thinking about a relapse in the future can have another transplant. And that's sort of probably the more common approach. Even that's not that common anymore. And no, one doesn't need to have had a transplant to have CAR T-cell therapy. The approvals just says somebody has to have 4 prior therapies, but doesn't say what those, the transplant's not one of the ones that has to be there. And then for the most part, we don't make our decision about collecting stem cells based on MRD status. That's, yeah. I'm so young.
Okay.
Are there known causes of multiple myeloma? Causes that you...
We don't know. Environmental exposure, there are some link with growing in a farm, right? Pesticides, Agent Orange, and some toxin, some link to different occupation, you know, it's exposure, so maybe a genetic predisposition. We were talking earlier with another person about the increased incidence of MGUS between siblings, which we're all surprised when they released the data. You know, the incidence goes up with age, 3% after age 50, up to 7-8% after age 70, and to see, you know, the incidence going up, sibling and African Americans, so definitely a genetic predisposition, and then environmental toxin exposure. Another thing, we are seeing a decrease in age over the last 20 years, and we don't know the reason why, but myeloma used to be a disease of the older population, and now it's getting younger and younger. So lots of environmental toxin exposure and probably a predisposition to acquire the disease.
What chemical exposures?
As I say, we know pesticides is a big one because Agent Orange and
even 9/11. So 9/11.
Yeah, 9/11.
Yeah.
Yeah.
And then just to add a couple more things, which I'll be talking about in the afternoon in my session. The talk is also modifiable factors that have been linked to the risk of development of myeloma, such as dietary patterns or BMI or diabetes and things. Again, we're not saying that one thing somebody did is a cause, but these are all things like, you know, what slightly increases the risk on a population level. And then it's hard to say whose myeloma was caused by what, because there are so many factors at play, and it's not a simple like one mutation or one cause, but there are multiple factors that increase risk.
But in my case, over my working years, I had a lot of exposures to benzene dyestuffs,
Benzene, yes.
chlorinated solvents, tire retardants, and I've also had bladder cancer, which I think those same chemicals probably contributed to that.
Probably, yeah.
But back in my working days, you know, you didn't know or weren't told to handle those chemicals or washing, dry cleaning solvent, you know. Thank you.
While I'm walking, can you address the fact that I know I've heard Bob Kyle say that MGUS has been in every myeloma patient at some point? Would you say that's true? That each myeloma patient started out with an MGUS?
I think so. We don't know how long the MGUS. For some patient is very short, for some patient is very long, but I do believe, that the myeloma is preceded by the MGUS.
And this has been looked at in a couple different studies. So Mayo Clinic, so Bob Kyle was one of the first to report on this, and then Walter Reed's the military hospital looked at this also. And basically what they did is they had tubes of blood in the freezer for many, many patients, and in most cases they looked at people who had myeloma. They looked back at tubes of blood that they had in the freezer to look back at whether or not these people had basically M spikes or had MGUS. And in essentially all cases they found that people did have MGUS in the past. So it's hard to test that prospectively, but at least based on the data we have, it seems that pretty much everyone who has myeloma had MGUS before it. But the key thing to point out is that most people with MGUS never develop myeloma. So MGUS is probably a requirement for developing myeloma later, but that does not mean that everyone with MGUS develops active myeloma later. And in fact, most people with MGUS will never develop myeloma.
Thank you. Hi. I had to write mine down. So I'm on lenalidomide maintenance, T414 following VRD, and I'm told that I'm a VLPR, partial response, and all my numbers are great. And so where I am, and I think, Dr. Christina, you mentioned something called escalating maintenance. Never heard that term before. Did you use that term? Escalating?
Escalating, yes.
Yeah, it's interesting. So let's talk about lenalidomide, Revlimid, generic or non-generic. And so I have side effects R11 to R15. So in the 21-day cycle, I have a lot of fatigue and a lot of other gastrointestinal issues in that mid-period. So I have two questions. One is, what does escalating maintenance mean? And the second is, at 76, I'm ineligible, they tell me, for transplant. So is there a pathway for me to, if I were to relapse, to get to bispecific immunotherapy?
There's so many questions I want to ask.
So start with the escalating maintenance.
I'll start with one place. One thing for patients that are on Revlimid as maintenance therapy, a very common side effect is GI side effects, and primarily diarrhea, and diarrhea that can be crampy and painful and sudden. And so this is something that's off. Right. I'm just, I'm narrowing it down to this one thing. And then I'm going to let everybody else answer all the hard questions. But we know why Revlimid as maintenance therapy causes diarrhea. It's because of bile acid malabsorption. And we have very good drugs that are called bile acid sequestrants. And there are old cholesterol medications, cholestipol or cholestyramine. And so I don't, if somebody's life is impacted by diarrhea and like you're making choices to not do things because of it, then I recommend getting on one of these medications. And I've had patients completely change their lives with being on one of these medications. And there's really only one side effect from these medications, and it's constipation. So, and you have to titrate your own dose. But I've had patients who've been on just huge doses of Imodium. They don't leave the house, and we just start on one of these bile acid sequestrants, and their life changes for the good. So if that's the problem, then we have a good solution for that.
Yeah, I agree, right? My question to you is, for how long have you been on Revlimid?
My BRD ended August 19th, 2022. I was diagnosed Groundhog's Day, 2/2/22, and then treatment, and so I've been on maintenance. What's that? About 6 months.
So you finished your RVD when?
August 19th, 2022.
But 2022. So you're not even a year.
Right.
And
yes.
and you
correct.
you have the 414 translocation.
Yes.
I would. Yeah, it will make me nervous a little bit. I have to say the truth. That means I will probably, I believe, on the proteasome inhibitor with your disease. I do have opened the clinical trial targeting your translocation at Duke a few weeks ago. But you have to fail at least 3 lines of therapy, unfortunately. But it's another pill that we're targeting your type of myeloma. But it will make me very nervous for several reasons, because you have not achieved the complete remission. You have high-risk myeloma, and you are on single-agent Revlimid, which probably is not enough for your disease. And nevertheless, at age 76, you look good, good performance status. The CMV-MTR done a retrospective study many years ago, 11,000 patients divided by age, less than 60, 69, above age 70, and compare these three groups. And the transplant-related mortality for age 70 plus was 0 because we highly selected this population of patients, and the outcome was similar. So the patients are selected, but they still can go to transplant in selected case. And with your high risk, I will probably have pushed that. Nevertheless, I will adjust the chemotherapy and your recovery time probably a little bit longer. But at minimum, I will add a proteasome inhibitor there.
Can I ask, have you been seen in a myeloma center? Okay, sounds good. But I guess what I would recommend, I mean, just based on what you're hearing, is that, as Dr. Kaufman's saying, there's a lot that we can do to manage side effects, such as Revlimid diarrhea, but not general oncologists don't always necessarily know this trick. And there are a lot of patients out there who are completely miserable on their Revlimid maintenance because this issue has not been controlled. Any myeloma specialist would tell you how to do this. Not to say your doctor has missed something, but just to say that this is one thing that can help that it sounds like has not been explored. What to do with this T414 thing is quite controversial, as you're hearing from Dr. Gasparetto. And then the other thing is she's pointed out in our group, including we did a study on this years ago, looking at older adults with myeloma. And as Dr. Gasparetto mentioned, we found that with appropriately selected people, meaning people that don't have a lot of other medical problems, people who are in good performance status, meaning they're up and doing their normal activities, the transplant is very safe. Now, once we get to 80, that's where, you know, age may no longer just be a number, but at 76, most transplant centers would not say automatically, just based on age 76, nope, we're not going to do it. Which is to say, you know, multiple things that it may be worth seeing a myeloma specialist for if you haven't already.
Hi, just a quick question. The patient up there who was MRD positive and considered to be in a complete remission, that's a little kind of confusing to me.
It should have been complete response. That was a mistake in terms of...
I'm sorry?
It should have been complete response. I think I wrote remission, but I meant response.
Oh, okay, thank you. That's all.
But no, I think your question is still relevant. So how do complete response and MRD, how do those two interplay? So basically you could think of MRD testing as MRD negative as sort of a deeper level of complete response. So complete response, not to get too into the standard criteria, but basically, so as the standard criteria for complete response are myeloma proteins completely gone from blood and urine, bone marrow biopsy shows less than 5% plasma cells. So even if we do a bone marrow and we see 3% myeloma cells, that's still a complete response. Whereas MRD testing looks at a deeper level to see if we can see those myeloma cells. So you're going to have a complete response that's MRD positive, meaning less than 5%, protein's gone, but we still see a few of those cells using that fancy MRD test, versus an MRD negative complete response where we can't see anything even by that fancy MRD test.
Thank you.
So there, it's sort of MRD is a deeper level of complete response.
Just a question. A couple of years ago, one of my wife's docs mentioned that they were trying to develop a blood test that would eliminate bone marrow biopsies. And they were working on that at MSK, as a matter of fact, Dr. Langren. And I'm just wondering if there's any progress that has been made with that.
Talking about the mass spec.
Yeah, so that I kind of alluded to that before when I answered the question about MRD. There is progress made. There are a number of different tests looking at mass spec, circulating tumor cells, circulating tumor DNA, but all of these are still in research and they are not standard of care. But I think it is to come very soon at some point where you will be using.
And they're already doing comparison. I think Angela Dispensieri showed some comparison on the stamina between MRD and mass spec. So the MRD on the peripheral blood was not really the best. We tried to do with the clonoSEQ MRD on the peripheral blood versus bone marrow, and it was not detecting the disease in, at the same level. Not yet. Soon.
Okay, so we have time for maybe 2 more questions. Okay, maybe hard for me to get in here. Thank you.
Yeah, it appears that the testing for multiple myeloma is fast, is great. It seems to be oftentimes quite accurate. Given that, what about holidays or breaks from taking medication? Since you have such good testing, what's theoretically wrong with relying on those tests to determine when you should get back on the medication?
The MRD, right? If you're negative, and those are the new study are designed like that.
Well, from what I heard over here, though, the MRD, that sounds a little not so accurate sometimes. I'm thinking more like kappa, lambda chain ratio, maybe some of the other blood testing.
Yeah.
Or maybe the bone marrow. And
it's usually a combination of looking at everything. We want to make sure with all the different testing the bone marrow, testing the blood, testing, a scan for imaging the bones, everything looks like there's no evidence of disease. And I think at this time, we don't have data on what happens when you discontinue if everything is clear. But there are a couple of studies ongoing. So there are 2 Len discontinuation studies or maintenance discontinuation studies that are small, one from University of Chicago and one from MSK, that have shown like where they're looking at if you're MRD negative 3 years apart in 2 bone marrow biopsies, can we stop maintenance and see what happens and how many patients myeloma actually comes back, or are they really staying in remission a long time after? And then there's a big randomized study, the dramatic study, which is looking at MRD guided maintenance and seeing whether patients really need to be on this long term and whether to change therapy based on it. So I think again, it's a very good question that eventually we will have answers for, but at this time, we don't know that if somebody's an MRD negative for a few years, should we stop? But
okay, well, in theory, though, I mean, if you only have like 5% cancerous cells, it can't be doing much in your body.
Yeah. So
in theory, what's wrong?
So what our worry is if your disease is under control with whatever drug you're on at this time, and we stop and take a break, that when it starts to rise again, you might have lost that drug's ability to work. And then you're on the next drug. And then there's and so that's our concern. So I mean, there are patients, I don't think about it in terms of breaks or holidays and things like that, because I very much worry about creating resistance with that approach, and that drug won't be helpful later. If somebody cannot tolerate a medication, then we should not be giving that medication. And if somebody's not tolerating the medication and is in a deep response, that's even more reason to stop. So that's my general approach. And again, I very much worry about it not being simple with the numbers coming back. If we, and so maybe with MRD testing, we can do that. We can say you're MRD negative, and if you peak up a little bit way before we see it under the microscope or see it in the blood, maybe we can get back to that maintenance. But that's a big maybe on our side.
Okay, and yes, I agree. And this is, again, where clinical trials are really important. I was looking at someone's data, I can't remember where they presented it, showing like patients that got to be down to MRD negativity. And then, the question is like, can I go off therapy at that time? And they showed that high-risk patients or some of the high-risk genetic features could get down to MRD negativity and sustain for a long period of time, but then they would eventually relapse. So that's what you're talking about, is the risk. Like, right. Do you want to take that bet or not? And that's where you need clinical studies. So, okay, at this time, we will thank them, our amazing panel.